Cyclomatic Arch. The basic views for the Cyclomatic Arch includes the SMV, tangential views, and also the AP axial town. So again, a lot of these views you'll see over and over and over again. So you're going to be familiar with the tube angulation, which baseline we're going to use for properly positioned facial bone studies. So again, this is very, very repetitive. The only thing that changes is where the central ray is going to be directed. So there's your AP, there's your SMV, there's your towns, and again, we've got the waters and we've also got the lateral. Okay, so you guys should be already familiar with the positioning. So this is the SMV for zygomatic arches. This is very similar to that of the SMV of the skull. Okay, only difference here is the technical factors that you use. Because the cheekbones are very small, very thin, we have to change our technical factors to accommodate for that thickness and lack of density to the cheekbone. So same thing applies here. We're going to direct the, we're going to place the IOML parallel to the image receptor, avoiding any type of rotation with the head, avoiding any type of tilt with the head. This is going to be one of the most difficult positions to achieve. It's hard to do it standing up. We do it sitting down, and if you do it sitting down, make sure that the chair that they're sitting on doesn't have any wheels. Okay, because what they're going to be doing is they're going to be leaning back, putting their head up against the image receptor. If it has wheels, it can roll out from underneath them, and now you have an accident. So instead of doing just cheekbones, now you're going to be doing skull x-rays. Okay? This is also an easy way of doing this. Placing the patient at the edge of the table, and we're using some kind of platform here. It can be like the, what is it, the laundry basket. Okay, and we use that as a counter or a table to place a sponge and the image receptor on top of that. If you don't have access to that, also the other thing that you can do is place a huge bolster behind their back as they're laying down, and naturally what's going to happen is their head's going to plop right back. Okay. Central ray is going to be directed 1.5 inches below the mandibular symphysis. Where's your symphysis? Just basically this. Okay. All right. So here's a radiograph of the bilateral zygomatics. Does it look like it's underexposed? Mm-hmm. Or is it just right? Okay, because we're not looking at this. We're focusing here on the arches. Okay, so it's going to look underexposed, but that's okay.
So we don't care about that.
Yeah, we don't care about that. And especially now with computerized, radiography, it's going to fix everything for you. So it should look very, very nice, very crisp. Okay, so again, it's going to be a demonstration of both zygomatic arches. It's going to be well demonstrated in profile. They should be symmetrical. What's going to happen here is if you don't have proper rotation, if you do have rotation or tilt, you're not going to see both. You'll see one, but the other one becomes occluded because of the rotation and tilt. Okay, so again, for a good SMV, you should see both. All right, so no rotation, optimal exposure. The mandibular symphysis is going to be superimposed over the frontal bone. The arches are symmetrical. They're also called jug handles. I think some of you guys were already using that term, jug handles, right? Okay. Next one here is the oblique infrasuperior. Just like the SMV, but we're going to do a couple of things here. So from an SMV, okay, head tilted all the way back, you're going to rotate your head 15 degrees. So you're going to rotate your head 15 degrees, and then you're going to tilt it 15 degrees.
15.
And I put a couple of arrows here so you understand the concept here. So from an SMV, you're going to rotate to the affected side. In this case here, it's the left side. So it's going to rotate 15 degrees, and then you're going to tilt it chin 15 degrees. So the chin is going to move towards the affected side. Does that make sense? Okay. So it's going to be 15, 15. Now, we're not looking at bilaterally, because again, if there's any tilt or rotation, you're not going to see the other side. So we're going to just focus on the one. Okay. Central ray is going to skim the ramus of the mandible. Okay. It generally enters just right about here, right where the jaw is, and you're going to skim it. That's why it's called tangential. I don't think you guys have heard that term for a while, since the beginning of the semester, or last semester. Okay, so we're skimming it. We're going to collimate to a very, very small area. There's no need to have a full 8 by 10 or 10 by 12. You're just collimating to the area of interest. If you don't collimate, not only is the patient getting overexposure, but the images may come out a little bit, what do you call that, grainy. So you're going to get some modeling. Okay. Any questions on the 15-15? So 15 rotation, 15-degree tilt towards the affected side. Okay, and you're only focusing on one, it's unilateral.
Thank you.
So one zygomatic arch is going to be demonstrated very well with no superimposition, again using optimal exposure factors. Okay, post collimation and also low KVP. Any questions?
70?
Pardon me?
Lower than 70?
About 65, about 70, yeah. Because we're skimming, you're not hitting anything really solid, so to speak. All right, AP axial. We're still on zygomatic bone, the arch. All right, the AP axial. You'll probably notice there's a little bit of difference between my slide and your slide. I started taking away these centimeters. It was bugging the crap out of me. Do we do anything in do you guys actually measure in centimeters?
No.
I don't know.
Okay, we're still in the old way, right? That's why I took it out. It was bugging me. Because I'm seeing both these numbers, and it's hard for me to focus on which number I need to lecture on. So I took it away. It's my OCD. Okay. AP axial. What's another name for that?
Towns.
Towns. Okay. So here's your Towns method. So depending on which baseline you're using, OML versus IOML. If you're using the OML, it's going to be 30 degrees. You may not have the individual tuck their chin down as far, so now what you're going to use is your IOML with a steeper angle of 37 degrees. Central ray is going to be directed 1 inch above the glabella, and you guys remember what the glabella is, right?
Mm-hmm.
To pass through mid-arches, pass through the mid-arches. Okay. There's another thing that they haven't mentioned here is your mid-sagittal plane. Your mid-sagittal plane should be what?
Perpendicular.
Should be perpendicular to the image receptor. Okay. Too light?
Well, you can
Just
see the
right.
see the arches.
Okay. Again, we don't care about what's going on here. We're focusing on the arches. Okay. Questions? We're just going to fly through this. Okay, mandible. Any questions on the zygomatic arches? Is a zygomatic arch, is it one bone?
It's 2 bones.
It's what?
3.
There's going to be several bones, right?
Mhm.
Okay, so you've got the zygoma. What else? The maxilla and also the temporal. You guys studied for that, huh? And it wasn't on the quiz? Sorry. Yeah, it's probably going to be on the test. All right. All true and false? All right. Now you guys are awake. Okay, basic views for the mandible includes the axiolateral and then the PA or PA axial. Again, here it comes again. What's this?
Towns.
Okay.
Caldwell.
No, Caldwell.
Caldwell. Okay. And then we have this special again, SMV, and then we'll just do a quick discussion on Panorex. All right. again, we're throwing in a bunch of angles in here. So when you're looking through your textbook, it can be very, very confusing. So an axial lateral mandible. If you place the patient in a true lateral position, you're going to get superimposition. Okay? So the body and the ramus will be superimposed on top of the other body and ramus in a true lateral position. Your jaw, or your mandible, is an arch, or an arc, however you want to call it, okay? So what we're trying to do is we're trying to open it up so you can visualize both body and rami. Does that make sense? All right, so to accomplish this, the magic number here is 25 degrees. The magic number is 25 degrees. This 25 degrees can be accomplished in several ways. If you place the patient in a true lateral position, okay, you guys paying attention? True lateral position. Your angle is going to be 25 degrees cephalad. Okay? Now, if the patient can go in a true lateral position and there is a head tilt, let's just say of 10 degrees, what should my angle be now? It should be what? It should be 15. All right? So your guideline here, your baseline that you're going to use here is your interpupillary line. You guys don't have this on your slides, right? I put it up here just for visual demonstration. So your central ray and your interpupillary line is going to form what? 25 degrees. Okay? Sometimes the tilt may be 20 degrees. Now what are you going to do? 5-degree angulation, okay? So the combination of your interpupillary line and your central ray is going to form 25 degrees. Does that make sense? All right. So in a true lateral position, we're going to tilt the head approximately, this is actually tilted 25 degrees because this is perpendicular to the image receptor. How you rotate the head, I'm not talking tilt, okay? It's how you rotate the head and the neck will demonstrate certain parts, certain anatomy of the mandible. So I'm just going to go ahead and jump forward here, and then I'll go back. Okay. So again, central ray, interpupillary line is going to form 25 degrees. Now, if I rotate the head now I'm talking about rotation. If you rotate the head 10 to 15 degrees towards the affected side, okay, what's the affected side? The side that's what?
Closest to the IR.
Closest to the image receptor. Okay? So when I turn 10 to 15 degrees towards the affected side, it's going to be a general survey. Okay, so it's going to be a general survey of the entire mandible. If I do 25 degrees, again, 25 degrees, interpupillary, and then I rotate it extremely 30 degrees, now we're looking at the body. Which body?
Closest to the IR, right?
Closest to the image receptor. Okay? The one that's going to be furthest from the image receptor is going to be superimposed with the rest of the facial bones. So this is the area that we're looking at for the body of the mandible. Okay? There's a lot of superimposition here, so you're not going to see anything. Okay? And then even more steeper, because now what we're doing is we are doing this. Okay? Even with a more steeper tilt, now we can see the mentum.
Is the mentum the same as the mental point? Okay.
The mentum is just the general area.
Okay.
The mental point is actually where the two bones
That's a
fuse.
tilt, not a rotation, right?
What's that?
A tilt, not a rotation?
This is a
A rotation.
This is a rotation for you. This is going to be this. You're still going to maintain the 25 combination of the head tilt and the tube angulation. Okay? Again, the 25 is going to be formed between your interpupillary and your central ray. So it's going to be this right here is, I'm spitting all over myself. So this right here is again, combination of central ray and your interpupillary is going to form 25. It's like this. Here's my image receptor. Okay? Now I'm going to turn it 45 degrees towards the image receptor. This one right here. Okay, again, 25, turn
30.
30 degrees. Okay, this one, again, we're 25, turn 10 to 15 degrees.
And that one right there is just no rotation.
This one here is just a true lateral.
No rotation,
So
just a 25
there's no
degrees.
rotation here. It's true lateral, perpendicular, no angulation, nothing.
Not even 25 degree?
Not even 25, because look, you see the entire mandible. They're superimposed
Okay.
on top of another. So this is a true lateral, true lateral. No angulation, no tilt, no rotation. Okay? Now these views can be, again, accomplished in different ways. You got to assess the condition of your patient. Are they able to stand up, or are they going to be laying down? Okay? So these are several ways that it can be accomplished. Again, we're trying to form 25 degrees here. We're forming 25 degrees here. Now, when you guys go out in the field and you're doing a mandible,
Go to the bathroom.
go to the bathroom. The technologist, your supervisors could say, just do an oblique. Okay? They really don't have a standard. All right? But for test purposes, okay, remember the 25. Remember the 30 rotation. Remember the 45 rotation. Okay? Remember those things, okay? Because in the field, they just say, oh, just oblique it, and you're done. But the degree of rotation and tilt are going to show different things. But aren't you guys finding that out right now, that whatever we're showing you here, is it exactly what you guys are seeing out in the field? There's a lot of variations. Okay. Lots of variations. Now here we have somebody in a trauma situation. They're not going to be able to go prone. They're not going to be able to go supine for you, so you're going to do a cross-table lateral. Okay? If they have a neck brace, especially, you don't want to be moving them around because you can cause additional damage to their neck. So here is a cross-table lateral. You guys are familiar with that term now, right? Cross-table. Okay, cross-table lateral. The only thing that's pretty weird about this is because we are shooting through the jaw, it is pretty thick, pretty dense. They should be using a grid, right?
Mm-hmm.
Okay, because if you don't have a grid, you're going to get scatter radiation. The image is going to look a little bit fuzzy, right? So we want to clean up the image a little bit better to avoid any type of modeling of the image, make it a little bit more crisp, okay? So, bless you. Patient in true lateral position. Here's the 25-degree angulation again towards the head. Okay, 25. And in addition, what we're going to do is point the central ray inferiorly. Because if we go true lateral, what are we going to hit? We're going to hit the shoulder. So we're going to bring the tube up a little bit and angle down. Just slightly to avoid any superimposition of the shoulder with the body of the mandible. Okay. Posteriorly, that means towards the back, right?
So that you're talking about the central ray, right?
The
Five
central ray.
to 10 degrees.
Yeah, so you're going in like this, and then you're going to angle 5 to 10. Okay, so lateral 5 to 10, because otherwise, if you're going straight lateral, you're going to hit the shoulder. We're trying to get the shoulder out of the way. Okay, any questions here? Okie dokie, artichoke. All right. Okay. What does this look like to you? Just by the way, it's not double exposed because it's going like this. It looks like it's double exposed, but it's going like this. Okay. Is this a 30 degree or 45 degree?
45?
I'm gonna say it's,
30.
I'm gonna say it's this.
30?
Yeah, this is too steep. So you can actually see the mandible right here. You can't see it here. There's still some superimposition. So that's probably about a 30-degree rotation. You can see, again, you can see the body and the rings very, very well. Okay, any questions, guys? But it does look like it's double exposed, right? Okay, PA mandible. PA mandible. Don't look at this. Let's look at this. PA mandible. So your OML, perpendicular to the image receptor. OML perpendicular to the image receptor. The central ray is going to be perpendicular to the image receptor, exiting the lips. You can do a 25-degree angulation towards the head. This does help better visualize the condyles and the neck of the mandible. In my time in radiology, this wasn't very common. This was more common. Why would we do this PA instead of AP?
Magnification.
I mean, we're not doing it for comfort, are we?
No.
Again, anytime you see positions like this, we're not doing it because of comfort. It's because we're trying to get the image receptor as close to the anatomy as best as we can. Otherwise, we have magnification. Magnification causes distortion. It can also change the degree of the resolution. Okay? Any questions here?
For the 25 degree, it would still exit the lips.
You're still going to exit the lips. Yep. At 25 degrees, you're still going to exit the lips. Can we do this AP?
Sure, why not?
Sure, we can. Do we do it AP most of the time? Yes, we do. Okay. All right, so the entire mandible should be demonstrated, no rotation with optimal exposure factors. Okay. AP axial mandible. What is this?
Towns.
This is your towns again, okay? So your OML. OML is going to be perpendicular to the image receptor. Now, with the mandible, the angles are a little bit steeper because with your with the skull, the zygomatic, it was between it was 30 or 37, right? So it's going to be a little bit steeper here because we're trying to evaluate the condyles. So the OML, again, same criteria and positioning though. OML is perpendicular to the image receptor, but with steeper angles of between 35 to 40 degrees caudally, centered at the glabella. Okay, because now we're moving a little bit lower in the anatomy. We're also going to move the entrance of our central ray. So now we're at the glabella. Here, the condyloid process and the condyle are going to be well demonstrated. Okay, it is bilateral, so we are seeing both sides. Any questions? Am I going too fast?
Mm-mm.
That's what I want to hear. Okay, SMV. SMV. Bless you. IOML, parallel to the image receptor in the central ray, is going to be perpendicular to that image receptor. Directed 1.5 inches below the mandibular symphysis. Okay, the entire mandible is demonstrated with no rotation or tilt, again with optimal exposure factors. So again, you get a good SMV when the mental area is superimposed with the frontal. If you are seeing any signs of the frontal bone over here, that means you're not getting a true SMV. Okay, so they need to extend their head a little bit more. All right.
Wait, can you say that again? Why wouldn't we see the frontal bone on that?
If this mental point and the frontal bone are completely superimposed, you're not getting a true SMV.
Not You're not angled enough?
They need to
Tilt back.
tilt back a
Farther-
little
farther
bit
out,
more.
right?
Right. They need
So
to
does that
extend.
mean-
What's that?
If they're superimposed.
If the mentum and the frontal bone are properly superimposed. If they're superimposed, you got a properly positioned SMB. Okie dokes?
Mm-hmm.
Thought you had a question. All right, you guys familiar with the Panorex unit?
No.
Okay, if you've been in the dental office, getting a
Oh.
survey,
Oh, yeah.
okay, right? At Anaheim Memorial, Anaheim Regional is what it's called now, we used to have a Panorex machine, and we did 1 or 2 of these a day. So what this does is that it's an X-ray unit that during the exposure, the camera, or the X-ray tube goes around your face. It's a special image receptor. It is coned, I shouldn't say coned, it's arched. And so as it sweeps around, portions of the Panorex image receptor is being exposed, so that when you do develop the image, it looks like this. Okay, so you guys familiar with this?
Mm-hmm.
Okay. Now in a properly positioned Panorex study, you need to see both the condyloid and the coronoid. Coronoid?
Yeah.
Okay, coronoid, okay. Condyloid and the coronoid. You need to see that. You also need to see what?
The
Okay,
mentum.
it's a mandible shot, right? So we also need to see the
point.
mentum. Okay? So this is not a good example because we're missing the top part. We got it over here, okay? But we don't have it here. This is cut off, and it's also cut off here. Okay. So to properly position for Panorex, the patient has to be in upright position. So the cervical spine has to be perpendicular with the floor or the surface of the floor. Okay? And then the IOML must be parallel to the floor. See, although the IOML is parallel with the floor here, this is not, okay, the neck is not, and what can end up happening is you can change the angle of your jaw. And then parts of the other anatomy may be included in the image that you're trying to avoid. Did that make sense? So yeah, so spine must be perpendicular, must be properly aligned, so perpendicular with the floor. IOML must be parallel with the floor. And it's one of those exposures, again, the exposure itself takes anywhere between 3 to 4 seconds, so it's just like zzz all the way around. Is that a lot of exposure? Okay, remember your reciprocity law? Okay, the length of the exposure might be long,
The mass MA would.
but MA is going to drop to maintain your total overall mass, total exposure. So maybe 3 or 4 seconds, but if I adjust my MA accordingly, then they should not be getting an overabundance of extra exposure. All right, are we good here?
Yes.
You want to start all over again?
No.
Yes.
We got it?
Mm-hmm.
Okay, TMJs. What's a TMJ?
Temporal mandibular joint.
Temporal mandibular joint. Okay, so AP axial, there it is again. Obliques. Okay, these are going to be some new ones I'm going to introduce to you here as modified law and also your Schuler's, and then the tomographic portion of doing TMJs. Now, when doing TMJs, they're generally done for comparison in open mouth and closed mouth. Has anybody done or observed a TMJ yet at their facility? Okay. So these are done open mouth and also closed mouth for comparison, because what happens here is when you open up your mouth, your jaw, you can feel your TMJ moving down anteriorly out of the fossa of the temporal bone. So it does move. So again, we do it for comparison. So here we go again. OML, perpendicular to the image receptor. Your angle is going to be 35 degrees. Center is going to be 2 inches above the glabella. Okay, 2 inches above the glabella. to exit the effect, to exit the effect, to exit the TMJs. So here we have the condyloid process in full view. Okay, it's actually this area right here. So here we have two different structures that we see up here. Here is your condyloid, and then here is the fossa of the temporal bone. So we are looking at the joint space in between. Can you guys see the outline?
Mm-hmm.
Condyloid, and then here is the temporal bone right here, and so we are looking at the joint space, the TMJ.